Hello, everyone. I'm Henry Lee, Professor of Pediatrics at the University of California, San Diego, and co-chair of the Neonatal Life Support Guidelines Writing Group. It's my privilege to welcome you to the Pediatric and Neonatal 2025 Guidelines Focused webinar, an event brought to you in collaboration with the American Academy of Pediatrics and the American Heart Association. This year, the guidelines update is even more exciting. For the first time, the guidelines we're unveiling today have been developed as a true 50-50 partnership between our two organizations. The three chapters we'll be presenting: Pediatric Advanced Life Support, Pediatric Basic Life Support, and Neonatal Life Support were each led by two co-chairs, one from the AHA and one from the AAP. The writing groups themselves were also balanced, 50% AHA members and 50% AAP members. That means the guidelines don't just carry one organization stamp. Rather, they reflect the combined expertise, commitment, and vision of both the AHA and the AAP. We're especially excited that these guidelines will be jointly published in Circulation, the AHA's flagship journal, and in Pediatrics, the journal of the AAP. In fact, the title itself reads the AHA and AAP Guidelines for CPR and ECC. This represents more than a new set of recommendations. It represents our shared commitment to advancing pediatric and neonatal resuscitation together. Now, let me give a brief overview of how these guidelines have been developed. It begins with ILCOR, the International Liaison Committee on Resuscitation. This is where experts from around the world, including the AHA representing the US and Canada, rigorously reviews the latest science. Throughout that process, they produce the Consensus on Science with Treatment Recommendations, or COSTAR. ILCOR's goals are to identify what the scientific evidence truly supports, see where gaps remain, and make recommendations where clinical practice needs to evolve. That work is the foundation for everything we teach, not tradition or opinion, but a focus on science. From there, the AHA and AAP take the COSTARs and translate them into guidelines that fit real-world practice in the US and Canada. Multidisciplinary writing groups like the ones we're celebrating today interpret the science and apply it to the situations you face every day. EMS calls, hospital codes, neonatal resuscitations. Every 5 years, that work becomes the guidelines for CPR and ECC, recommendations that are clear, evidence-based, and actionable. Then comes the final step, making sure those guidelines don't just stay on paper. They are embedded into education programs like NRP, PALS, and PBLS. These courses are how you, as instructors and clinicians, carry the science into classrooms, simulations, and ultimately to the bedside. The journey goes from global review of science to guidelines to education and finally to action. This is what makes today so important. Science doesn't just stay in journals, it flows into practice through training, learning, and performance. It's my honor to introduce the writing group representatives who will walk us through today's updates. Dr. Javier Lassa will begin with Pediatric Advanced Life Support. He is Associate Professor in Critical Care and Cardiology at Children's Health in Dallas and co-chair of the 2025 Pediatric Advanced Life Support Writing Group. Dr. Lassa is internationally recognized for his research in resuscitation science, particularly concerning extracorporeal resuscitation. Next, we'll hear from Dr. Tia Raymond, who will cover Pediatric Basic Life Support. Dr. Raymond is a pediatric cardiologist and cardiac intensivist at Medical City Children's Hospital in Dallas with over 20 years of experience. She is co-chair of the 2025 Pediatric Basic Life Support Writing Group and has been a longtime leader within the AHA. And then Dr. Edgardo Shield will present the Neonatal Life Support updates. Dr. Shield is a professor of pediatrics at Indiana University and a global leader in neonatal resuscitation research. He is co-chair of the Neonatal Life Support Writing Group and has contributed to international practice changes for more than 2 decades. Together, these colleagues represent the depth of expertise and collaboration that went into developing the 2025 guidelines. I will hand it off to Dr. Lassa, who will start us off with Pediatric Advanced Life Support.
Hi, and thank you for the introduction, Henry. My name is Javier Lassa, and I'm a pediatric cardiologist, critical care medicine specialist, and faculty member at Children's Health and the University of Texas Southwestern Medical School. I'm the co-chair of the 2025 PALS Advanced our Pediatric Advanced Life Support Writing Group, and I'm here representing the American Academy of Pediatrics. It's important to recognize that this is the first time that the AHA has been joined by the American Academy of Pediatrics to co-sponsor the guidelines, bringing together expertise from both groups as well as ensuring that science experts and leadership from both organizations align and approve the guidelines before their publication. I'm excited to join you to share some insights into the 2025 PALS guidelines, but first want to acknowledge our amazing writing group team, as well as Dr. Alexis Topchin, my esteemed co-chair for the 2025 PALS writing group. Dr. Topchin is an internationally recognized resuscitation scientist and former co-chair of the 2020 combined PALS and Pediatric Basic Life Support Guidelines writing groups, on whose behalf I'm presenting today. Now, before we dive into the PALS guidelines, it's important we review some important background information and some epidemiology regarding pediatric cardiac arrest. We know that cardiac arrest in infants and children doesn't usually result from a primary cardiac cause. Rather, it's more frequently from the results of progressive respiratory failure or shock. Of note, every year in the United States, about 20,000 children will experience cardiac arrest in the hospital, compared to about 7,000 out-of-hospital cardiac arrests. Now, of arrests happening outside the hospital, the majority of EMS-treated arrests happen in the home environment, which is why training the general community, especially parents, on CPR is so important. When discussing outcomes after cardiac arrest, we often talk of survival, and the most common way it's described in the scientific literature is survival to hospital discharge. So for out-of-hospital cardiac arrests, unfortunately, only about 6% overall will survive to discharge. While for those who do make it to the hospital, a little over a third, or about 38%, will make it out of the hospital alive. So that's about 1 in 3. And that's just survival, as survival with good neurologic outcome is lower. In contrast, survival to hospital discharge after in-hospital cardiac arrest ranges from about 38% for pulseless cardiac arrests, and those with pulseless ventricular tachycardia or ventricular fibrillation, to 66% for bradycardia with a pulse, those events. And while we are starting to see that we're over 50% survival for some pediatric cardiac arrest patients, these survival rates have unfortunately plateaued over the past decade. So much more work is needed to keep moving the needle. And so what we're going to be going over next is the PALS top 10 list. Now, in 2020, we introduced the concept of top 10 take-home points. And we want to do that again in 2025. And we continue to emphasize the importance of high-quality CPR as we currently understand it, namely that providers should focus on appropriate chest compression rates, as well as age-appropriate depth, allowing full chest recoil, and with a focus on minimizing interruptions, all the while providing adequate ventilation for our pediatric patients while avoiding hyperventilation. We continue to emphasize the importance of epinephrine administration via IV or intraosseous every 3 to 5 minutes during arrest. However, we now distinguish between initial shockable versus non-shockable rhythms with regards to the timing of the initial dose of epinephrine. And epinephrine should be administered as early as possible for non-shockable rhythms, namely pulseless electrical activity and asystole. And this was based on a meta-analysis that found that earlier administration was associated with favorable outcome. For patients with a shockable rhythm, defibrillate early and resume compressions quickly after shock delivery. Now, with regards to defibrillation, we just discussed the importance of rapid defibrillation and potentially administering epinephrine if defibrillation is not possible. But again, emphasizing the importance of the early defibrillation. With the publication of a single center and now multi-center studies, the data is stronger to support targeting a diastolic blood pressure greater than 25 millimeters of mercury in infants less than 1 year of age and greater than 30 millimeters of mercury in children who are receiving CPR, because these thresholds are associated with higher rates of return of spontaneous circulation and survival to discharge. For end-tidal CO2 monitoring during cardiac arrest, while we continue to support its use to monitor the quality of CPR, there are newer data that suggest that end-tidal CO2 alone is not accurate to terminate resuscitative efforts. What we've seen is that almost half of children with a median event end-tidal carbon dioxide level less than 20 millimeters of mercury achieved ROSC in a multi-center study looking at survival to discharge. And post-resuscitation care is an important element of the chain of survival, and we continue to emphasize the need to avoid fever, as avoiding central hyperthermia above 37.5 degrees Celsius is associated with better neurologic outcome in infants and children who remain comatose after cardiac arrest. We also have a change in recommendations for post-cardiac arrest care related to blood pressure management. We're now recommending that clinicians target both systolic and mean blood pressures, not just systolic, but both systolic and mean. And we should target age adjusted 10th percentile as the lowest end of the blood pressure. And this was based on several studies, but really a large multi-center study that found that post-arrest systolic and mean blood pressures greater than 10th percentile was associated with higher rates of survival with a favorable neurologic outcome. In 2024, the ILCOR, or International Liaison Committee on Resuscitation, put together a very comprehensive systematic review looking at the predictive accuracy of clinical examinations, electroencephalography or EEG, biomarkers, and neuroimaging with favorable and unfavorable neurologic outcomes. These extensive data are the foundation of our new neuroprognostication guidance, which also includes a fantastic new graphic for the community. The biggest take-home point for this neuroprognostication section is, first and foremost, to avoid prognostication with a single modality. None of them are accurate enough at any time point to accurately prognosticate, and they carry the risk of inaccurately predicting error outcomes when used in isolation. We also highlight the importance of recognizing the ongoing physical, cognitive, and behavioral challenges for survivors and their families after cardiac arrest. Next slide. And lastly, for pediatric patients with tachyarrhythmias, specifically supraventricular tachycardia or SVT, new data support the use of IV sotalol as an antiarrhythmic for cases of SVT that's unresponsive to vagal maneuvers, IV adenosine, and electrical synchronized cardioversion when expert consultation is not available. Now let's dive into some of the significant changes. In 2020, we recommended administering the initial dose of epi during cardiac arrest within 5 minutes of starting chest compressions. We now emphasize the administration of epinephrine as early as possible for non-shockable rhythms. A recent meta-analysis of retrospective observational studies showed that shorter time to administration of epinephrine during pediatric cardiac arrest with initial non-shockable rhythm was associated with favorable outcomes. As mentioned during the top 10, when considering termination of resuscitative efforts, it's vital to avoid using a specific end-tidal carbon dioxide level alone, as survival has been noted in patients with average end-tidal CO2s less than 20 millimeters of mercury. For patients with an arterial line in place during CPR, we had previously recommended titrating to a diastolic blood pressure. However, there had been insufficient data to provide a target. And with the publication of a single center and now multi-center studies, the data is stronger, supporting a diastolic blood pressure target of greater than 25 millimeters of mercury in infants less than a year of age and greater than 30 millimeters of mercury in children who are receiving CPR, because thresholds were associated with higher rates of return of spontaneous circulation and survival to discharge. As for post-cardiac arrest management, new evidence supports maintaining post-return of spontaneous circulation systolic and mean blood pressures greater than 10th percentile as compared to the 5th percentile in 2020. And we now have a much expanded section on neuroprognostication and have provided updated language, emphasizing the need for multiple modalities, of course, at various time points throughout the post-cardiac arrest period for prognostication. Again, avoid single tests conducted in isolation. And lastly, we've expanded the scope of post-arrest survivorship and recovery recommendations to ensure providers objectively measure and address morbidities through multidisciplinary rehabilitation services for survivors as well as for families. Now, we're going to be transitioning over to the algorithms. The cardiac arrest algorithm here remains relatively the same for 2025, with some minor edits as shown in these red boxes. We strive to simplify the language surrounding high-quality CPR as well as medications. However, overall pathway and the recommendations for either shockable or non-shockable rhythms remain the same, with a shock, then epi approach for shockable rhythms and emphasizing, again, early epinephrine for non-shockable rhythms. For the pediatric bradycardia with the pulse algorithm, we've adjusted the decision and action items to make it clear when CPR is indicated. The remainder of the algorithm remains the same. And as for the pediatric tachycardia or tachyarrhythmia with the pulse algorithm, we've added some helpful language to help healthcare providers distinguish probable sinus tachycardia from probable supraventricular tachycardia. Now, the remainder of the algorithm remains unchanged. And lastly, we've updated the post-cardiac arrest care checklist and hope this helps healthcare providers provide a comprehensive approach to post-cardiac arrest care. And with that, I thank you for joining the webinar and now turn it over to my esteemed colleague, Dr. Tia Raymond, who will be presenting and reviewing important highlights and changes for pediatric basic life support.
Good morning, and thank you, Dr. Lassa. As stated, I am Tia Raymond, a pediatric cardiac intensivist at Medical City Children's Hospital in Dallas, Texas, and I am the co-chair for the 2025 Pediatric Basic Life Support Guidelines representing the American Heart Association. I first want to thank all of the members of the PBLS writing group for all of their help, as well as to my co-chair, Dr. Benny Joyner, who is the representative from the American Academy of Pediatrics. Before we get started, I just want to reemphasize that these guidelines were co-developed by the AHA and the AAP, and that this presentation represents the 2025 guidelines for basic life support during cardiopulmonary resuscitation and emergency cardiovascular care of the pediatric patient, excluding the newborn infant, and represents the first comprehensive update of the treatment recommendations since 2020. These guidelines are based on the best available resuscitation science. For clarity, the pediatric BLS guidelines apply as follows. Infant guidelines apply to infants younger than approximately 1 year of age. Child guidelines apply to children approximately 1 year of age until puberty. And for those with signs of puberty and beyond, adult BLS guidelines should be followed. Just like the PALS guidelines, the PBLS guidelines also have a top 10. Early recognition and action, key to pediatric basic life support. Immediate recognition of cardiac arrest is vital to improve outcomes. For infants and children who are unresponsive with abnormal breathing, including gasping, rescuers should activate EMS and initiate high-quality CPR, beginning with chest compression. High-quality CPR continues to be the foundation of resuscitation. The key components of high-quality CPR include providing adequate chest compression rate and depth, minimizing interruptions in CPR, allowing full chest recoil between compressions, and avoiding excessive ventilation. Respiratory conditions remain the major cause of cardiac arrest in infants and children, and as such, appropriate interventions to support ventilation and oxygenation should be initiated quickly. For out-of-hospital cardiac arrest in infants and children, providing breaths in addition to chest compressions improves survival. Thus, lay rescuers are encouraged to provide breaths if able and willing. A respiratory rate of 20 to 30 breaths per minute is recommended for infants and children who are A, receiving CPR with an advanced airway in place, or B, receiving breaths and have a pulse. For infants, the recommended compression techniques include using either one-hand technique or the two thumbs encircling hands technique. If the rescuer cannot physically encircle the chest, it is recommended to compress the chest with the heel of one-hand technique. The use of two fingers along the sternum was eliminated due to the ineffectiveness in achieving proper depth. For infants and children in cardiac arrest, an automated external defibrillator, or AED, should be attached as soon as possible using both a pediatric attenuator and pediatric pads if they are available. Prompt defibrillation for ventricular fibrillation and pulseless VT is critical, with minimization of peri-shock pauses. For infants with severe foreign body airway obstruction, repeated cycles of 5 back blows, alternating with 5 chest thrusts, is recommended. Abdominal thrusts are not recommended in infants. In children with severe FBAO, guidance is the same for infants with repeated cycles of 5 back blows, alternating with 5 abdominal thrusts, as opposed to solely abdominal thrusts. So what are the significant changes? One is foreign body airway obstruction. This is a major change from 2020, where the intervention for children with severe FBAO was abdominal thrust only until the object was expelled or the child became unresponsive. The recommendation now is repeated cycles of 5 back blows, alternating with 5 abdominal thrusts until the object is either expelled or the child becomes unresponsive. Chest compressions. This is also a major change from 2020, where the use of 2 fingers was still a recommended technique. The removal of this recommendation for chest compressions in infants also removes differences in chest compression technique between single and 2 rescuer CPR in infants. Previously, it was recommended that a single rescuer use a 2-finger technique and 2 rescuers use the 2-thumb encircling hands technique. Now, for either single or 2 rescuer, either 2 thumbs or the heel of 1 hand is recommended for CPR in infants. Terminology changes. In 2020, the intervention for choking in an infant was referred to as chest compressions. For 2025, this has been updated to chest thrusts to align with educational materials and delineate this as a choking intervention and not a sequence in CPR. Terminology changes for the BLS guidelines apply to children from infancy until puberty. PALS guidelines apply to infants and children up to the age of 18 years. This created confusion on when to use 2 rescuer compressions to breath ratio of 15:2 in children. We have added terminology to the guideline algorithms as well as the educational materials to clarify that a ratio of 15:2 is only to be used for prepubescent children. So in summary, prepubescent children should have 15:2 with 2 rescuers. Post-puberty onset with 2 rescuers should be 30:2, and any age when there is only 1 rescuer, it should be 30:2. We are no longer using the terminology rescue breaths, but rather just breaths. Additionally, we do not use BVM. Bag mask device or bag mask ventilations is now used. New algorithms for the 2025 PDLS guidelines include 2 new algorithms for infant and child foreign body airway obstruction. It is important to differentiate between mild foreign body airway obstruction, where the patient is coughing and making sounds, and severe FBAO, where the patient cannot make sounds. Patients with mild FBAO can attempt to clear the obstruction by coughing, but intervention is required in severe foreign body airway obstruction. The infant FBAO algorithm is on the left, where 5 back blows alternating with 5 chest thrusts is recommended. On the right, the algorithm for child foreign body airway obstruction, where repeated cycles of 5 back blows followed by 5 abdominal thrusts is recommended. And for both the infant and the child, if the infant or child becomes unresponsive, then CPR is to be immediately initiated. Updated algorithms include single rescuer for healthcare professionals to the pediatric BLS algorithm, which again includes infants to puberty. Of note, if the child has a pulse, and that is definitely felt within 10 seconds, if they are breathing normally, then you continue to monitor the child. If a pulse is felt but breathing is abnormal, then ventilations are to be initiated with one breath every 2 to 3 seconds. If the heart rate falls below 60 and there was a witnessed collapse of this child, that single rescuer is then responsible for activating EMS if this has already not been done, as well as retrieving an AED and defibrillator immediately and placing that. If there was not a witnessed sudden collapse, that single rescuer is to stay with the child and to continue CPR with a cycle of 30 to 2 until an AED arrives or until advanced providers arrive. And as previously stated, if there is a shockable rhythm, the patient is to be shocked as soon as possible. Next slide, please. Additionally, updated algorithms for 2 or more rescuers for the healthcare provider, very similar to the one provider. The only difference is that if there are 2 providers, then the second provider should be sent immediately to get the AED and defibrillator. Otherwise, the algorithm for 2 or more rescuers is the same as the single rescuer. And finally, we have a new updated infographic for pediatric BLS for lay rescuers. And again, this is for infants to prepubescent children. Acting fast, calling for help is very important. Calling 911, shouting for help, and asking someone to get an AED is critical. Then, if the infant is not breathing normally, CPR with chest compression should be started immediately. For the infant, we recommend the heel of one hand. For children, we recommend 2 hands with a ratio of 30 to 2. Once the AED arrives, it is to be placed and prompts for the AED are to be followed with continuing CPR and breaths until medical help arrives. And with that, I would like to introduce Dr. Edgardo Shield, who will present the 2025 Neonatal Life Support Guidelines.
Thank you, Tia. Hello, everybody. I am Edgardo Shield. I am a professor of pediatrics and clinical research director at the Neonatal Perinatal section at the University of Indiana in Indianapolis. I am presenting the summary of the NLS guidelines on behalf of the writing group, and I'm the co-chair representing the AAP. My co-chair, Dr. Henry Lee, represents the American Heart Association. As the previous speaker presented, we'll start reviewing our top 10 take-home messages for neonatal life support. We'll review later our new newborn chain of care that starts with prenatal care and extends to recovery and appropriate follow-up in the postnatal period to ensure optimal short and long-term health for the infant and family. A newborn resuscitation requires anticipation and preparation by providers who train individually and as teams. We are insisting in the need of the team approach to increase the effectiveness of neonatal resuscitation. Most newborn infants do not require resuscitation and can be evaluated and monitored during deferred cord clamping for 60 seconds or more and can maintain skin-to-skin contact with their parents after birth. We highlight the importance of both promoting deferred cord clamping for 60 seconds and preventing early separation from the parents. We continue to highlight the effective ventilation of the lung, as indicated by the rising heart rate, is the first priority in newborn infants who need resuscitation. However, if the heart rate does not rise with initial ventilation we may need ventilation corrective steps, including the use of an alternative airway, such as laryngeal mask or endotracheal intubation, that may be required. Monitoring temperature during resuscitation helps to avoid hypothermia and hyperthermia, both of which are associated with adverse outcomes. We cannot emphasize enough the importance of temperature management, and that skin-to-skin contact may be an important source of heat for the newborn infant. Pulse oximetry is used to guide oxygen therapy and meet oxygen saturation goals. We should not provide oxygen without measuring oxygen saturation and titrate accordingly. Chest compressions are indicated if the heart rate remains less than 60 beats per minute after appropriate ventilation corrective steps, which preferably include endotracheal intubation. We want to have a secured airway during chest compression. If the heart rate remains less than 60 beats per minute after chest compression, epinephrine is indicated, preferably via an intravenous route. The endotracheal route is accepted until an intravascular access is obtained. And finally, if all steps of resuscitation are effectively completed and there is no heart rate response for 20 minutes, redirection of care may be discussed with the team and family. Let's now focus on the significant changes. As I mentioned earlier, umbilical cord management is one of the big changes, and we separate the recommendation for term and preterm infants. For term newborn infants who do not require immediate resuscitation, deferred cord clamping for at least 60 seconds can be beneficial when compared to immediate cord clamping. For newborn infant born at less than 37 weeks of gestation, speaking about premature infant, who do not require immediate resuscitation, deferred cord clamping for at least 60 seconds is recommended when compared to immediate cord clamping. As you can see, this is a big change in time and duration that we recommend for the cord clamping. Regarding chest compression, we continue saying that it may be reasonable to compress over the lower third of the sternum when providing chest compression to newborn infant. In addition, it may be reasonable to change the compressor roll every 2 to 5 minutes when providing chest compression to newborn infant, and to switch the compressor during the heart rate assessment period. This is an important new recommendation that we included this time. As you know, it has been recommended for adults and pediatric patients for a while. However, this is the first time for us recognizing that the neonatologist and the newborn provider may perceive fatigue, and they will reduce the effectiveness of chest compression for prolonged during time. Therefore, we recommend to change the provider between 2 and 5 minutes. Oxygen administration, we insist that the pulse oximeter should be placed as soon as possible for newborn infant receiving respiratory support or supplemental oxygen. And we also now recommend a ventilation rate between 30 and 60 inflation per minute in newborn infants, because the evidence shows that as lower rates, we can obtain better tidal volume. And we also now have a new visual aid. As I mentioned earlier in the first take-home message, we have the 2025 Neonatal Guidelines has a new newborn chain of care that starts with prenatal care and extends to recovery and appropriate follow-up in the postnatal period to ensure optimal short and long-term health for the infant and family. As you can see, the link 1 is prevention. The health of the pregnant person has a direct impact on the health of the newborn infant. and this should include a comprehensive prenatal care. We move to the link 2, that is called recognition and activation. The need for assistance must be anticipated and recognized to reduce the risk for poor outcomes. When appropriate, based on anticipated risk, a qualified team with advanced resuscitation skills should be present at the time of birth. Moving to the link 3, initial steps, is where we summarize all the activities that we will present later on the algorithm, and this is the initial step for stabilization and resuscitation. And as expected, our link 4 is ventilation. We cannot insist more about how crucial is appropriate ventilation, and we know that delaying ventilatory support in newborn infant increases the risk of death. So providing appropriate ventilation as soon as possible is critical. However, if ventilation is not enough, advanced resuscitation requires a comprehensive approach to address a life-threatening situation in newborn infants. If initial steps and ventilation with an alternative airway do not improve the heart rate, then providing advanced intervention are crucial. We move to the link 6, where we speak about postnatal care. We know that most healthy newborn infants can remain with their parents, prioritizing bonding, breastfeeding, and thermoregulation immediately after birth. On the other hand, newborn infants who require resuscitation beyond initial steps require further observation and monitoring. And finally, recovery. Ensuring appropriate primary care follow-up for all newborn infants after birth is critical. We'll introduce an updated algorithm, and we made some changes to align with the new recommendation. One of them is the umbilical cord management emphasized that, as you can see in the third box on the right, we added a box about the management of umbilical cord management to highlight and emphasize how important it is to defer cord clamping at least for 60 seconds. We changed the table on the bottom right about oxygen saturation targets. As you can see that this table now begins at 2 minutes, as deferred cord clamping for 60 seconds or more typically results in oxygen saturation not being routinely measured at 1 minute. And finally, the EKG integration, we move it earlier in order to be ready to detect better and evaluate the heart rate when we detect bradycardia, and to have an accurate measurement of the heart rate during chest compression. Now, I will pass the podium now to Henry Lee, who will present some educational new products to you. Thank you for your attention.
Thank you again for being with us today and for bringing life-saving techniques to the field. Before we close, I want to leave you with a few important reminders. First, as of today, the NRP 9th edition and the updated PALS materials are officially launched with the release of the 2025 guidelines. These updates reflect the new science you've heard about today, and all of the changes are being built directly into the educational and training resources you rely on. You can be confident that the courses you teach are always grounded in the latest and best science, as demonstrated throughout this webinar. Second, we want to make sure you have opportunities to go deeper into these updates. We'll be sharing podcasts that highlight key changes, AAP webinars that provide deep dives into PALS and NRP, and RES scientific sessions content designed to support instructors and clinicians with additional insights. In the meantime, if you have additional questions, please visit the American Heart Association Instructor Community, a private online space for instructors to ask questions related to CPR training and resuscitation science, as well as learn from one another. There you can join the 2025 Guidelines discussion forum and connect with peers. You can access the instructor community after logging into Atlas. And for those of you who do not have access to Atlas, we encourage you to reach out to your regional American Heart Association office. For NRP instructors, please visit the Instructor Toolkit for updated resources and information on implementing NRP 9th edition. Finally, keep an eye out for emails and other announcements in the coming days with links to recordings of this session as well as other webinars that took place today. On behalf of the American Heart Association and the American Academy of Pediatrics, thank you for joining us and for the life-saving work you do every day.